Payment 28. Transparent payment multiplication series with non-enhancing well-defined doppler and homogeneous low-attenuating lesion in the rectal space with thin peripheral calcification. Amide was intermediate signal T1 in areas of high signal within and high signal T2 with septate. And trachea. Now, simple. The patient has paid multiplication. Then she shows a well-defined doppler and homogeneous low-attenuating lesion in the rectal space with thin peripheral calcification. So lower attenuating lesion in the rectal space with the rectum and then thin peripheral calcification, and MRI finding is intermediate on T1 with I on T2 with separate diagnosis anterior axis. Simple. Question number 29. Other options don't make any sense. So anterior axis. Right iliac fossa pain, tubular fluid filled lesion in the right lower quadrant abdomen. CD shows a prominent appendix of high attenuation, 30 Hans per unit. Diagnosis mucosal of the appendix. Now, right iliac fossa pain, tubular fluid filled lesion in the right lower abdomen in the right iliac fossa. So there's CD shows prominent appendix of high attenuation, 30 Hans per unit. So diagnosis mucosal of the appendix. Next question number 30. Budd-Chiari syndrome, small nodal liver and ascites. Okay, small nodal liver and ascites. Doppler shows absence of blood flow in the left and middle hepatic veins, mostly cause absent flow in the hepatic veins, Budd-Chiari syndrome. Now, patient has a small nodal liver and ascites, small nodal liver and ascites, and then on our Doppler ultrasound there will be absent flow in the hepatic veins, diagnosed Budd-Chiari syndrome. There's also enlarged quadrate lobe. Question number 34. Intermittent abdominal pain. Seem lipase and amylase were marked raised. CD shows pancreatitis with multiple calcification. MI the common bile duct and the ventral pancreatic duct drain into the middle papilla and the lower pancreatic duct drain into minor papilla, diagnosed pancreatic division. Pancreatic division. Now, okay, MI shows the common bile duct and the ventral pancreatic duct drain into the major papilla. Common bile duct and the ventral pancreatic duct drain into the major papilla, and total pancreatic duct drain into the minor papilla, diagnosis pancreatic division. Now, what do you see on MRI? There is the common bile duct and the ventral pancreatic duct drain into the major papilla, and the total pancreatic duct drain into the minor papilla, diagnosis pancreatic division. Now, this is pancreatic division. MRI findings: common bile duct and main pancreatic duct drain into ventral pancreatic duct drain into the major papilla, and the total pancreatic duct drain into the minor papilla, diagnosis pancreatic division. Question number 35. Fever and abdominal pain, hepatosplenomegaly with multiple cervical, mediastinal, and parotid lymph nodes, diagnosed non-Hodgkin lymphoma. Now, the hint is hepatosplenomegaly with multiple cervical, mediastinal, parotid lymph nodes, diagnosed non-Hodgkin lymphoma. Multiple cervical, mediastinal, and parotid lymph nodes, diagnosis Hodgkin lymphoma. 37. A hernia just lateral to the right rectus muscle with an obstructed tube of small bowel, diagnosis Pickering hernia. Hernia just lateral to the right rectus muscle with an obstructed tube of small bowel, diagnosis Pickering hernia. Hernia, okay, just lateral to the right rectus muscle with an obstructed bowel loop of small bowel, obstructed tube of small bowel, diagnosis Pickering hernia. 38. Palpable hard lump in the abdominal wall, post laparotomy, CT scan to the soft mass with ill-defined margin, the rectus muscle showing mild contrast enhancement, amyloid on T1 and T2, diagnosis desmoid. Now, CT scan to the palpable hard lump in the abdominal wall, post laparotomy, CT scan to the soft mass with ill-defined margin, the rectus muscle showing mild contrast enhancement, amyloid on T1 and T2, diagnosis desmoid. Left rectus abdominal mass lesion with mild post-contrast enhancement in tract rectus sheath, diagnosis desmoid. Again, desmoid tumor. They also in the muscle desmoid tumor. It's rare tumor, but in this MCQ is described as CT scan for the short mass with defined margin in the rectus muscle showing mild contrast enhancement, diagnosis desmoid tumor. 39. History of complicated appendix surgery. CT scans with diffuse cystic abnormalities in the abdomen pushing the bowel loop centrally, filling the lesser sac with scalloping of the hepatic and splenic margin, diagnosis perizomatomy. Now look here. History of CT scan shows diffuse cystic abnormalities in the abdomen. Diffuse cystic abnormalities in the abdomen. Cystic abnormalities in the abdomen. Putting the bowel loop centrally. Cystic abnormalities in the abdomen. Putting the bowel loop centrally. Filling the lesser tract, and then the scalloping of the liver border, hepatic border, and splenic margins. Scalloping of the liver border and splenic margin. Diagnosis: Pseudomacdonald peritoneum. Now again, CT scan shows cystic abnormalities in the abdomen. Putting the bowel loop centrally, and then scalloping of the liver and spleen margins. Diagnosis: Pseudomacdonald peritoneum. Pseudomacdonald peritoneum with mental shaking. Next, question number 40. Diabetic man has recent regional transplant, has dysphagia, parents with longitudinal oriented filling defect in the upper and middle esophagus. She shows converting thickening of the upper part of the esophagus that was candida esophagitis. Now look here, this is a corrosive esophagitis, this is candidal esophagitis, this is herpes simplex esophagitis. Now again, diabetic man has recent, parents with longitudinal oriented filling defect in the upper and middle esophagus. Notice that these are circular, these are longitudinal filling defects. Longitudinal filling defects in the upper and middle esophagus, longitudinal filling defects. And then there, on CT scan, there will be circumferential thickening of the upper half of the esophagus that goes candida esophagitis. Now, on barium spread, the longitudinal filling defects in the upper and middle esophagus, diagnosis candida esophagitis. The superficial ulcers seen in herpes esophagitis, superficial or shallow ulcers. And corrosive esophagitis shows smooth narrowing in the part of the middle esophagus. Question 42. Male smelling of alcohol, has chest pain and vomiting. Chest active with pneumomediastinum, cervical emphysema, and left hydropneumothorax. Diagnosis: Perhaps syndrome. Pneumomediastinum shows perforation. Now look here, this is Perhaps syndrome. Pneumomediastinum, air in the mediastinum, pneumomediastinum. Chest active shows pneumomediastinum, cervical emphysema, and left hydropneumothorax. So it's diagnosis: Perhaps syndrome. History of alcohol and on chest active pneumomediastinum, diagnosis: Perhaps syndrome. Pneumomediastinum shows perforation. Okay, this is next question. Number 43. 70-year-old man has pain and distension of the abdomen. Abdominal X-ray to dilate inward U shaped sigmoid colon. Barium enema shows smooth curved tapering of the barium column like hooked peak at the distal colon. Diagnosis: sigmoid volvulus. Again, the sigmoid volvulus, the fecal volvulus, the gastric volvulus, gastric volvulus, gastric volvulus, gastric volvulus, sigmoid volvulus, sigmoid volvulus. Fecal volvulus, you can see the Hofstra pattern, and cecal volvulus, you can see the Hofstra pattern. Now, an X-ray, there's dilate introverted U-shaped sigmoid colon or coffee bean sign. On barium enema, there's smooth curved tapering of the barium column. Barium enema, there's smooth curved tapering of the barium column like a hooked beak. The distal colon. Diagnosis: sigmoid volvulus. Next, question number 44. Again, this giant sigmoid volvule diverticulum. Not volvulus, sorry, giant sigmoid diverticulum. Same in past papers. It looks like football sign, but it looks like a big cyst with a soft inside center, like a big volvulus, like soft inside giant sigmoid diverticulum. Question 44. On mucosal review, barium study views tortuous, serpiginous, longitudinal, reduced, and filling defects upper esophagus, endoscopic ultrasound with multiple anechoic spaces in the submucosal region with thin walls. Diagnosed: superior vena cava obstruction with downhill varices. Again, the esophageal and gastric varices. Here. On barium swallow, there are tortuous, serpiginous, longitudinal, reduced, and filling defects in the upper esophagus, endoscopic ultrasound with multiple anechoic spaces in the submucosal region with thin walls. Diagnosed: superior vena cava obstruction with downhill varices. Now, the filling defects will be in the upper esophagus, but there will be downhill varices. Question 45. Obese woman MRI shows diffuse low signal intensity of the liver on T1 out of phase gradient echo images. Diagnosed: fatty liver. A patient obese and then MRI shows diffuse low signal intensity of the liver on T1 out of phase gradient echo images. Diagnosed: fatty liver. Question number 46. Ultrasound shows 2 cm anechoic lesion in segment 2 of the liver. It has smooth margins with no detectable walls, no separation. C on per unit of 10. Diagnosis: simple hepatic cyst. Ultrasound of 2 cm anechoic lesion in segment 2 of the liver. It has smooth margins with no detectable walls, no separation. C on per unit of 10. So HU on per unit of 10 shows cyst. So diagnosis: simple hepatic cyst. Question 47. Barium meals with multiple small barium collections with surrounding loosened arrows in the distal body and on the stomach. Diagnosis: erosive gastritis. This is acute gastritis, erosive gastritis. Correct? Now, erosive gastritis. Barium meals with multiple small barium collections, multiple small barium collections with surrounding loosened halos, in the distal body and anteromal stomach. In the body and anteromal stomach. Diagnosis: erosive gastritis. Now, again, barium meals with multiple small barium collections surrounding loosened halos in the body and anteromal stomach. Diagnosis: erosive gastritis. Multiple collections with surrounding loosened halos in this body and anteromal stomach. Diagnosis: erosive gastritis. Question number 49. Barium studies of fetal left tubular narrow stomach, area gastric are absent. Diagnosis: aortic gastritis. Barium studies of featureless tubular narrow stomach, and area gastric are absent. Diagnosis: aortic gastritis. Now question number 50. Let's check 50.
Sir, please check question number 48, which is absent in your video.
48 क्या? 48 नहीं है. अच्छा 48 नहीं.
48 absent.
हाँ ठीक. 48. A 70-year-old man with a history of alcoholism presents with progressive dysphagia. Barium studies of the upper gastrointestinal tract with irregular narrowing of the esophagus, judge of the gastrointestinal junction with abrupt transition to non-mucosal proximal. Diagnosis:
ऑप्शन ए आंसर है की में तो अल्सरेटिव कार्सिनोमा ऑफ एसोफेगस.
अच्छा एक मिनट. क्वेश्चन 48
की देखें.
Occurring carcinoma of the esophagus. ठीक है. Based on risk factors and irregular stricture in the esophagus, carcinoma should be considered for diagnosis and direct visualization with histopathology is recommended. ठीक है. यहाँ से क्योंकि इसका risk factor alcoholism की है, because he has alcoholism risk factor and there are irregular stricture in the esophagus. 48-year-old man with history of alcoholism and progressive dysphagia. And then barium studies of upper gastrointestinal tract shows irregular narrowing of the esophagus just above the gastroesophageal junction with a rough transition to normal mucosa approximately. Diagnosis: occurring carcinoma of the esophagus. Question number 50. 60-year-old woman presents with history of acid reflux and chronic cough. The chest radiograph with 5 cm radiocardiac shadow in the midline with air fluid level. Diagnosis: hiatus hernia. Now, because she had a history of acid reflux disease and chronic cough, and then on chest radiograph there's 5 cm radiocardiac shadow in the midline air fluid level, so diagnosis most likely is hiatus hernia. It cannot be lung abscess because lung abscess will be seen in the lung. Bronchogenic cyst also is seen in the subcranial region. Then bronchogenic carcinoma is seen in the lung, and left lower collapse is also seen in the left lung. So most likely diagnosis is hiatus hernia.